Dr. Leocadio Rodriguez Mañas, Director of the Global Aging Research Network of the International Association for Gerontology and Geriatrics. It is my great pleasure to introduce to all of you this set of webinars focused in the benefits and prescription of physical exercise in older people, jointly to other sponsors, including the Public University of Navarra, the Spanish CIBER on Frailty and Healthy Aging, and the Regional Health Service of Madrid. This course, coordinated and led by Professor Miquel Izquierdo from the Public University of Navarra, will address the general issue of physical exercise in several conditions and diseases, and also in different settings of care and approaches, from prevention to treatment. To achieve this purpose, the course has met an outstanding group of speakers. I would like to take advantage from this opportunity to express them my deepest gratitude. All of them are among the highest experts in the world in their field of interest. Moreover, all of them have led some of the most contributing studies to show the benefits of physical exercise in this group of population, the older people, the way of implementing the programs, and the target populations among this population, with a preferential focus on those who are frail. Recently, many of them have contributed to the document International Exercise Recommendations in Older Adults, Expert Consensus Guidelines, published at the end of the last year in the Journal of Nutrition, Health and Aging. This document, I think, means a true milestone for all of those working with older people. I am pretty sure that this set of webinars will fill some of the expectations of the attendees and will contribute to strengthen the role of IAGG in helping to the provision of the best care to all the citizens. Thank you very much for your interest in this web series.
Hello, I am Miquel Izquierdo, Professor of Physiotherapy and Exercise Science in the Public University of Navarra and the Navarra Biomed in Pamplona, Spain. First of all, I would like to thank Professor Rodriguez Mañas, Director of the Global Aging Research Network and the International Association of Gerontology, to the opportunity to coordinate this seminar, as well as the geriatrics and the panel of experts and professors who will participate in this online seminar entitled Exercise Recommendations in Older Adults, Update State of the Art. Experts are going to talk about the important role that both structured exercise and overall physical activity play as preventive strategies for many chronic diseases, including cardiovascular disease, stroke, diabetes, osteoporosis, and obesity, improvement of mobility, mental health, and quality of life, as well as reduction in mortality, among other benefits. Notably, exercise intervention programs improve the hallmarks of frailty. For example, low body mass, strength, mobility, physical activity level, and energy, as well as cognition, optimizing functional capacity during aging. They also highlight in the manuscript that the role of the exercise in the prevention of disease and the management of several age-related diseases and conditions is increasingly evident, including syndromes for which the benefit of pharmacological treatment is controversial. Despite its multiple benefits, exercise is not fully integrated into geriatric medicine practice. It is still absent from the core training of most geriatricians and other healthcare professionals. Also remark that in an area of complex regenerative medicine, when some scientists are even considering the expansion of human life well beyond its known limits, we must not forget the simple and important messages. Exercise is not just for children and younger adults. People of advanced age can adapt to exercise and deserve to benefit from it. In this regard, we will give you a quick look on the recent international expert consensus guidelines of exercise recommendation in older adults, and finally we will focus on BB-Frail multi-component exercise program. Hope you enjoy it and like it. Thank you very much. Professor Andrew Coates was born in Melbourne, Australia, and studied medicine at Oxford and Cambridge. He has published over 20 patents and more than 1,500 publications and has more than 120,000 career citations and a personal age index of 144. He served as editor-in-chief of the International Journal of Cardiology from 1999 to 2016 and has served on more than 10 major journals editorial boards. Andrew is an expert on heart failure. He first described the muscle hypothesis on chronic heart failure that explained dyspnea and exaggerated ventilation response in cardiovascular heart failure patients. He first described chemoreflex overactivity in cardiovascular heart failure and periodic breathing, and published the first ever randomized trial of exercise for cardiovascular heart failure patients. Andrew has been chairman or committee member of the following major cardiovascular and cancer cachexia clinical trials: Christmas, Charms, Copernicus, Oxfam, Optimal, Overture, Replace, Seniors, Augment HF, and At1. He has served head of cardiology at Imperial of Medicine and deputy vice president at the University of Sydney, and has joined academic vice president of Monash University, Australia, and the University of Warwick in United Kingdom. He's presently president of the Heart Failure Association of the ESC. The title of the talk is Why Bed Rest Was Replaced by On Your Bike for Heart Failure Patients.
Hello, colleagues, ladies and gentlemen. My name is Andrew Coates. I'm president of the Heart Failure Association of the European Society of Cardiology, and I'd like to talk about exercise in heart failure, something that's been throughout my career, something I've been interested in, and my observations over these 20 or 30 years. First of all, just a comment about heart failure, because it's a very common and very important condition. Over 60 million patients worldwide. It's the most common reason for hospitalization, patients aged over the age of 65 years, and about a quarter rehospitalized within a month of discharge. But still, about 50% of patients diagnosed with heart failure will die within 5 years, despite the advances in treatment we've seen. And we have seen very many advances over 20 or 30 years. When I was a medical student 30 years ago, we were told not to bother telling a patient they had heart failure because there were no effective treatments. But now there are more effective treatments to reduce the composite of mortality and heart failure hospitalization risk for heart failure than any other condition in medicine, about 9 separately proven treatment. However, there's still a very big burden. If you look at the global population with heart failure, estimates vary, but you see between 1% and 2% of the developed world would have heart failure. But what we're seeing is that low and middle income countries and areas that traditionally had a very low rate of heart disease are now dramatically expanding. So we expect that there'll be a lot more heart failure in the future. These estimates in terms of the increase in the prevalence and burden of heart failure are really quite scary. And if we look forward another 10 or 20 years or so, then we'll see a great increase in both the cost, the number of cases, and the years lost due to disability. The estimated trend is a growth in prevalence of 15.1% increase, and years of living with disability only by 10% by the year 2030, and it'll account for nearly $400 billion in worldwide expenditure. So why is it such an important disease? Well, it's not just the statistics of how many people have it and the high risk of mortality, but it's got a huge burden on our patients. So we have a high degree of symptomatic disturbance. We have a significant reduction in physical function and quality of life, and self-efficacy is dramatically reduced. That leads to social limitation and the need often for institutional care. Symptoms can be aggressively increased. We can measure that by simple scores such as the NYHA class, New York Heart Association class, between class 1 with minimal restriction to exercise to class 4, who really are almost bedbound. And we can do quantitative measures with scores such as Kansas City Cardiomyopathy Questionnaire score. But these patients are left with dramatic symptom disabilities. The problem is that all those successful treatments we have, predominantly drug, but some device treatments, that reduce the risk of mortality or be admitted to heart failure, admitted to hospital for heart failure, are actually not as good at improving functional capacity and quality of life as we would like. So we're left with a very large number of people who are being protected from mortality, but not being improved in their quality of life. So we need to look further. So when we have the heart failure patient, we obviously, first of all, concentrate on the initial cardiac damage, be that myocardial infarction or other heart muscle diseases. But we've learned over the last 30 or 40 years that there's important impact on other organ systems, particularly the kidney due to reduced renal perfusion. We have direct effects further worsening the heart by remodeling, and a major dysfunction of skeletal muscle and vascular function. And they contribute very importantly to reduced physical activity. And this is something that I devoted many years of my career investigating. From our early studies in both Oxford and London, we documented the following observation, which at the time was really unexpected, and that is an extremely poor and virtually no correlation between left ventricular ejection fraction, the most common summary measure of the impairment of the left ventricle in heart failure, and objective ability to exercise as measured by peak oxygen consumption. You see that there's no correlation. Patients can have severely impaired ejection fraction, but a reasonable exercise tolerance, or any mildly impaired ejection fraction with an extremely poor exercise capacity. And the fundamental difference is shown here as one of the major contributors to what makes some patients very limited. And this is biopsy from leg muscle in patients with heart failure on the right and an age-matched normal control on the left. You see a dramatic reduction in skeletal muscle bulk, shift in fiber type, and very abnormal skeletal muscle function, a really significant acquired skeletal myopathy. And that, of course, can explain some fatigue. We went into much greater detail using magnetic resonance spectroscopy and showed that there's early acidification of muscle in chronic heart failure compared to normals, and early loss of high energy phosphate. So there are major metabolic abnormalities that go with the structural changes I showed you in the biopsy results just earlier. To summarize a lot of work over about 20 years, there's a substantial loss of bulk, that the amount of muscle in the legs in a heart failure patient may be reduced by 50% or more. There's abnormal blood perfusion, very early fatigability of the muscle, shift in fiber types, and selective atrophy of certain muscle fibers, abnormal metabolism, whether it's measured by gross biopsy studies, by magnetic resonance spectroscopy, or whether it's done by looking at mitochondrial function. And there's apoptosis and inflammation within the skeletal muscle itself, as well as deficiency of growth factors and resistance to the action of growth factors on skeletal muscle. Now, that could explain fatigue, but patients with heart failure also get severe shortness of breath. And we couldn't really explain why that shortness of breath should be caused if the patient wasn't congested and there was minimal pulmonary edema left. But one explanation is the following observation. During exercise, there's an increase in the rate of CO2 production on the x-axis. That's the rate of CO2 being produced from the exercising muscle, and the amount of ventilation that the lungs need to do, measured by ventilation liters per minute. And what you see as heart failure gets more severe, so the amount of ventilation for the same degree of CO2 production goes up quite dramatically. That may be a 2 or 3-fold increase in the ventilation needed to excrete a certain amount of CO2 produced by the exercising muscle. And that's such a severe abnormality that at peak exercise, a quarter or more of all exercise consumption capacity is being used by the respiratory muscles themselves rather than the exercising skeletal muscles. Furthermore, this VEVCO2 slope, the degree of ventilatory response to exercise, is a very powerful independent prognostic marker and a marker of the severity of heart failure. And it's not explained by pelvic congestion. It's much more easily explained by the abnormalities in skeletal muscle. And here's some early work we did in Oxford in the 1990s. My colleague Massimo Pierpoli showed that if you study muscle reflexes that sense the abnormal skeletal muscle metabolism and feed in through the lateral spinothalamic tract, they lead to reflex responses that are well known in terms of sympathetic vasoconstriction, driving muscle blood flow towards the exercising muscle, but they also have a significant ventilatory response. So abnormal skeletal muscle metabolism stimulates skeletal muscle afferents within the muscle that then through the spinal cord lead to a reflex hyperventilation. So they explain that wasted ventilation we see here during cardiopulmonary exercise tests. And actually, they can cause a severe sensation of dyspnea, even when the lungs are not congested. So that allowed us to hypothesize what we call the muscle hypothesis of heart failure, where initial left ventricular damage within heart failure causes an initial beneficial neurohormonal response that is compensating for low perfusion pressure and low blood pressure, but that maintained neurohormonal response causes further damage to the heart muscle and skeletal muscle that leads to organ dysfunction in a number of organs that lead to reflex effects, such as that muscle reflex I showed earlier, that leads to signs, symptoms, but can further worsen the left ventricular function by leading to prolonged sympathoexcitation and abnormal neurohormonal balance. And we can also see that that has impacts fairly widely. If we look at the normal situation, the inputs to the central nervous system that a sympathoexcitatory, marked with a plus, are relatively underactive, whereas the ones that are inhibitory to the sympathetic nervous system, such as chemoreflex, are inhibitory, are quite active. And therefore, you get a predominant vagal output with relatively minor sympathetic tone. But in heart failure, you get a change, and the excitatory reflexes are very exaggerated, showing thicker lines, and the inhibitory inputs are inhibited. Sorry, I misled you before. Arterial chemoreceptors are sympathoexcitatory, relatively underactive in the normal situation, relatively overactive within heart failure, as are muscle metabo or ergoreceptors. So the abnormal skeletal muscle of heart failure, which develops after the heart disease, leads to chronic sympathoexcitation that leads to exaggerated ventilatory response, as well as exaggerated sympathetic activity that further worsens the condition of the heart failure patients. So then we and others, groups around the same time, thought, how do we stop this consequence? And one way was to target the skeletal muscle itself and take the opportunity of training muscle groups. So we did the first ever controlled trial of exercise training in heart failure some 30 years ago, and we randomized patients on the transplant waiting list for heart failure to bicycle exercise training versus normal avoidance of exercise. And we saw a significant increase, about 20% in exercise duration, also a significant increase in peak VO2, but those effects seen after 2 months training were completely lost during a 2-month period of detraining. That was then confirmed with many, many groups showing similar studies. To summarize a lot of these studies, there were hemodynamic benefits of training within heart failure, such as an increase in cardiac output, a reduction in peripheral resistance, increased leg blood flow, and increased endothelial function, as well as muscle capillarity. However, these changes were not particularly dramatic, and they weren't as strong as the changes we saw within skeletal muscle itself. In terms of skeletal muscle, we see increased improvement in morphology, increased function of muscle, including peak work rate, strength and endurance, a reduction in early fatigability, and improved metabolism measured in a number of different ways and using a number of different metabolic systems. We also saw ultrastructural changes in terms of improvement of fiber size, capillary density, and mitochondrial cristae improvement. These have all been summarized by my colleague, Massimo Piapoli, in the publication in 2001. When we go back to the reflex input I told you about, the muscle ergoreflex that causes the exaggerated ventilatory response as well as sympathoexcitation, when we take the abnormal muscle and train it, we see that that ventilatory exaggerated ventilation shown here by the amount of ventilation being held up above normal was partially improved by exercise training and brought closer to what we saw in control subjects. So we can reverse that abnormal skeletal muscle impact on sympathetic tone and ventilatory control by training the muscle group. The detraining effect shows exaggerated ventilation, whereas the training shows a correction towards normal. When it comes to other autonomic measures, which, if our hypothesis is correct, that improving muscle reduces sympathovagal imbalance, then we should see improvements in autonomic tone in heart failure with training. And that's true, and we and others have shown increases in measures of vagal tone, such as total heart rate variability and the ratio of high frequency to low frequency oscillation in heart rate variability. We see increased baroreflex sensitivity, which is sympathoinhibitory, reduced chemoreflex sensitivity, which is sympathoexcitatory, and reduced ventilatory responses to CO2, as well as reduced catecholamine levels and turnover, and reduce circulating and skeletal muscle immune activation. So all of these things are suggesting a beneficial shift in the autonomic milieu of heart failure towards that closer to a normal younger person. Now, of course, we would have liked to have known that this has an overall impact on total mortality in heart failure, but it's very difficult for this non-commercial option to get big funding for clinical trials. So we did an individual patient data meta-analysis of all training trials in heart failure, and we showed a significant impact on total survival by patients in these early training trials. Of course, we would like to see that prospectively evaluated in a single large trial. Here we also have heart failure hospitalization or survival showing a significant benefit as well. And the ACTION HF trial looked at what benefits might be achieved in terms of all-cause mortality and heart failure hospitalization. That was a trial with pre-randomization cardiopulmonary exercise tests and echo, randomization 1-to-1 with a median follow-up of 2.5 years, as published by Wheeler and O'Connor in 2007. And it got tantalizingly close to being a positive trial for this significant major outcomes. You see that the primary analysis showed a 7% trend to benefit, but the p-value was 0.13. If it was adjusted for baseline variables, it was a significant effect, but not by the principal statistical analysis. So we technically do not have a positive trial, but on the background of the meta-analysis and the fact that adjusting for baseline covariates showed a significant effect, it's strong evidence that at least training is safe, along with the major symptomatic and physiological benefits associated with exercise training. Furthermore, if we look at composite endpoint of SIBO mortality and heart failure hospitalization, we see that the effects are also even greater, with a 13% reduction p-value of 0.06 or a 15% reduction when adjusted for baseline covariates. Of course, in this, the true value of exercise training is improving the symptoms and functional capacity, and we see big increases in 6-minute corridor walk test distance, cardiopulmonary exercise test duration, and peak VO2. We see that to 3 months as well as to 6 months. Now, it's not just one form of exercise. These were mainly done with aerobic exercise using bicycle or calisthenics, but we also see it with other modalities, such as Tai Chi exercise. We need an exercise regime that the patients feel comfortable with and want to incorporate into their lifestyle. And we can see improvements in measures of quality of life, such as the Minnesota Living with Heart Failure Quality of Life score. We also see intermittent exercise can lead to bigger improvements in peak VO2, even than continuous exercise, both in terms of peak VO2 and intermittent being superior to continuous exercise training. So the mode of exercise also matters. We also see improvements in a large number of trials looking at inspiratory muscle training. So this is now training the particular muscle group that is abnormal in heart failure, that of the respiratory muscles itself. And that can spill over to improvements in overall exercise capacity, such as walk test distance and peak VO2. There are also interesting new targets for exercise training in heart failure, new organs, new types of exercise, and new patient groups who may be target for the benefits of exercise training. One is to see whether training can augment other established treatments, such as cardiac resynchronization therapy, biventricular pacing. And this trial showed after a patient had CRT, you can get further increase in peak VO2 by adding an exercise program at the end of the CRT stabilization period, as well as an improvement in NYHA class. We can also see benefits in patients with long-term ventricular assist device post-transplantation, even with inspiratory muscle training. You see an increase in peak VO2 in patients dependent on left ventricular assist device, that there's further benefit from then training their respiratory musculature. We also see some benefits, although it's not as well studied, in heart failure with preserved ejection fraction, where the problem is not systolic impairment, but diastolic impairment. And there is evidence from the XDHF trial that you can improve diastolic function in heart failure with preserved ejection fraction patients. We can also see improvements using other forms of exercise. Now, a very interesting recent trial that we had a chance to comment on in New England Journal of Medicine was the Rehab HF trial. And this is highly relevant to see whether we can continue the benefits of rehabilitation and exercise training to the sickest sick and the patients who are most frail. And this is a trial called Rehab HF, and it was a very pragmatic trial done in patients admitted with acute decompensated heart failure. Patients were elderly and they were in hospital for an acute admission for heart failure, recruited during the hospital admission. There were very few exclusion criteria, therefore it's applicable in real world practice. The ability to recruit these patients was augmented by very simple inclusion criteria. The patient only had to be able to walk 4 meters even with walking assistance. Therefore, there were a very high percentage of patients who were clinically frail or pre-fail. The intervention was a multi-domain rehabilitation program developed specifically for older heart failure patients who have a high rate of frailty. And it was designed to improve balance, mobility, strength, and endurance using reproducible targeted exercise through a multidisciplinary care team. You see here that there are levels of training, and it could start with rising from the chair without support, standing balance, endurance, mobility, gait speed, that could be assessed to detect patients with frailty, and then they could target the limitations and do personalized exercise rehabilitation to improve these very simple tasks. So there was enrollment and randomization before hospital discharge, multi-domain rehabilitation intervention was initiated, and then there was facility-based rehabilitation sessions 3 times per week, continuation in the home environment, and home exercise twice a week, leading to maintenance home exercise unsupervised 5 days a week with initial 3 months and then a follow-up of 6 months. This was published, the design, about 5 years ago. The primary outcome was the short physical performance battery score, which is a marker that can be applied to very frail patients. And the effect was highly statistically significant with a large treatment effect of plus 1.5 units in a score that averaged only about 6 at baseline. We also saw, when we look at the subgroups, that this improvement was relatively uniform, not affected by age above and below the age of 70, by gender, race, ejection fraction above or below 45%. There was benefits also in class 3 to 4 heart failure, the most severe heart failure patients, and other significant comorbidities did not affect that. Patients who were non-frail or pre-frail and patients who had frank clinical frailty also benefited significantly from these interventions. And we see their spillover to improvements, positive 34 meters in 6-minute walk test. We saw improvements in the Freed frailty criteria, improvements in the Kansas City cardiomyopathy questionnaire, a very substantial improvement in quality of life, as well as a reduction in a specific geriatric depression score. In summary, diverse, frail, older populations with a high comorbidity burden, with recent heart failure hospitalization, with markedly impaired physical function and quality of life, can have excellent retention and adherence to a rehab program and produce large, significant improvement in the short physical performance battery that was relatively uniform across many subgroups. this was clinically a highly meaningful improvement in other clinical measures, which for this very limited population could translate to very major clinical benefits. So in summary, overall, the present state of exercise rehabilitation for heart failure is that in stable chronic heart failure patients, exercise training has been shown to improve functional capacity, improve quality of life, improve multiple risk markers and adverse pathologies, possibly reduce heart failure hospitalization, and all with no worsening, and possibly improving mortality. There's emerging evidence suggests value of novel training regimes such as resistance training, inspiratory muscle training, also in heart failure with preserved ejection fraction, in the elderly and even frail heart failure patients, and in patients recently admitted for acute decompensated heart failure. So we have a very practical intervention at our fingertips. We've known about for centuries that exercise can be good even for severely limited patients with heart failure. Thank you very much.